Welcome to this edition of the TIRO Multidisciplinary Seminar Series. This morning we have a wonderful group of clinicians and experts with us. Just a reminder that we have some really wonderful podcasts described as the Voices of Wisdom. These are short 10 or 15 minute presentations that really focus with leading thought people from all over the realm of thyroid cancer into very practical clinical applications. So I've really enjoyed listening to them. We're putting out about one a month, and there'll be a lot more coming down the pike. So share those with your fellows, share those with the people that you're working with. And then the next slide. So this morning we've got a wonderful tumor board. We'll go around here and let folks introduce themselves. Dr. Alexander.
I'm Erik Alexander. I'm an endocrinologist up in Boston, Brigham and Women's Hospital.
We have a young, new up-and-coming surgeon, Dr. Shaha.
Good morning. I'm Ashok Shaha from Sloan Kettering. I'm an endocrine surgeon here at Memorial on the Head Neck Service. And just for your information, I work with Mike Tuttle and Lina Pedraza. So, you know, I'm kind of suppressed all the time.
Yeah, shy and suppressed is how we generally introduce you. Dr. Girshman.
Hi, Jeff Girshman, one of the radiologists here at Memorial, and I work with Ashok and Mike at our DMT conference with a special interest in thyroid cancer.
Perfect. Dr. Baloch.
Zubair Baloch. I'm a pathologist at University of Pennsylvania Medical Center in Philadelphia.
Fantastic. Thanks, Zubair. And this morning, I'll give a special shout out to Laura Boucai. Laura Boucai is one of our thyroid cancer attendees at Memorial that's well known to this audience. She ended up not being able to come this morning, so we're going to have Dr. Pedraza, who's one of our fellows, present. But I'd ask Laura for this presentation to give us just some very practical cases. So sometimes in the tumor board, we do all kinds of exotic stuff and weird stuff and all kinds of things. It's interesting, but in today's discussion, the cases are really going to focus on what do we really do? How do you really evaluate some of these nodules? Who do you really give radioactive iodine to? And to be honest with you, these are the discussions that we have every day in clinic among our group. So we'll be interested to sort of think out loud about these cases and see how we're doing. All right, let's pull down and we'll let Lina bring the cases up. Dr. Pedraza is one of our second-year endocrine fellows with us in our program with an interest in thyroid cancer. I'm very happy to say that when she graduates us this summer, she'll be joining Valentina Tarasova's Advanced Thyroid Cancer Fellowship down in Moffitt. Not sure how she got away from me and Dr. Tarasova stole her, but I'm proud that she's going down there. All right, so Lina, let's get started. What do you have for us?
Good morning, everyone. Thank you so much for being here. So we have a first case. This is a 54-year-old man who was found to have a thyroid nodule on an annual physical exam. That was back in 2020. The neck ultrasound showed the presence of a 1.4 by 0.9 by 1.2 centimeter solid isoechoic nodule in the isthmus with well-defined borders and didn't have any calcification. He did not have any other nodules on the right or the left lobes and did not have any cervical lymphadenopathy. The patient was completely asymptomatic. He didn't have any changes in his voice or any difficulty swallowing. His blood test, his thyroid function test was also completely unremarkable. So he had a FNA that revealed Bethesda 6 PTC.
Okay, hold right there for me. Go backwards one. Jeff, when you're doing this ultrasound, I check off a box that says ultrasound, but in the community, do I order ultrasound? Do I order lymph nodes? From a practical standpoint, what do you want to see from us when we ask that question?
Well, standard at Memorial, we do a full survey of the thyroid, central neck, and lateral neck for obvious reasons. Unfortunately, for many, many years in the community, that was just not being done. People would just simply get the dimensions of the lobes, report on some of the nodules, and now be the end of it. That, of course, is not the standard of care, and I think the community is catching on more and more, although we still do plenty of foreign interpretations where we just get the imaging of the thyroid, and we have no idea what the nodal status is, and that's extremely important for every single reason. So yes, we do that as standard, and it should be done.
Gotcha. Ashok, just initial thoughts. This is 50-year-old. Even I can probably feel this nodule in the isthmus at 1.5 centimeters. Sort of, what are you thinking about this case at this point?
Well, the evaluation is very appropriate. I think Jeff mentioned at Memorial, we always look for the central and lateral nodes. That's our practice. You go to Florida, you have to order 2 separate ultrasounds. So it is a little different, but it's a practice of the institution because Jeff and his colleagues, they know we're interested in the lymph nodes, more also in the primary tumor. Now, if you look at this primary tumor, it's well encapsulated. It's involving the isthmus only, not going on the either side of the thyroid lobes, which is very important to appreciate. Now, the nodules in the isthmus, which are mobile, and you can practically pull it up from the trachea, I think those are very favorable nodules. We try to avoid them on active surveillance as best as possible. Could they be actively surveyed for a while? Yes. Eventually, he's 54. He's going to come to surgery. In next 45 years, his tumor is going to grow, probably go in the either side of the thyroid lobe. So I think this is what we think all the time. This surgery is pretty simple. We'll talk a little more when you come to surgical intervention. I just want to add one more thing. As a surgeon, this ultrasound is very nice. It gives you the whole idea. But the CAT scan is something that is quite helpful. The 3-dimensional view of the whole thyroid nodule extend into the surrounding areas, how close it is to the trachea, and is there a plane of cleavage between the thyroid and the trachea? I think that is very important. The one last thing I just want to add, the isthmus is a very small organ, 3 centimeter thickness. So anything more than that is going to come out of the thyroid. So don't be surprised to find there is extra thyroidal extension in these tumors. That's almost a given in all isthmic thyroid tumors.
Jeff, let me come back to you for a second because you do ultrasounds and you do radiology. Help me understand what the CT scan tells us that maybe we don't see as well in the ultrasound and vice versa.
With respect to nodal status, as we've discussed many times in DMT, it is extremely helpful to get a CT scan, especially as a baseline preoperatively. We've had over the last 15 years or so adopted that more and more, and I'm happy to see it. The reason is ultrasound is operator dependent, and depending on how meticulous the sonographer is going to be, how meticulous the attending, and how often they go into the room, depending on how busy the day is, things can be missed. And even recently, we had a case that was scanned where, unfortunately, an operation was done. 6 months later, came back for the normal surveillance, and lo and behold, there's all this lateral disease. Obviously, the lateral disease was there preoperatively. We just failed to recognize it, and that's one of the failures of ultrasound. So, we used to worry about the radiation dose. Oh my God, should we radiate all these people? It's not that big of a deal. Let's do it. And I find that it helps a lot with nodal status. And of course, the things that are hidden, like retropharyngeal adenopathy, we're never going to see on ultrasound. Regarding thyroid, you can see extracapsular extension with both modalities, CT and ultrasound. Again, it's operator dependent on ultrasound, how meticulous you want to be. And also, you can create extracapsular extension just by moving your hand a little bit, and you can hide it that way too. With CT, you see ill-defined borders. It's sort of a hazy look, and you can find that to be very helpful. So they're complementary, and they're not perfect, but I'm glad that we're getting more and more CT imaging for patients.
Zubair, on a related question, the biopsy is Bethesda room number 6, and I always thought that was like 100% thyroid cancer, and we saw a case a couple weeks ago that it was Bethesda 6, read by our team, and when we took it out, it wasn't thyroid cancer. Does that happen, or should I be worried about that? Trade my cytologist in? Help me with that.
Mike, you can hear me clearly, right?
Mm-hmm. Gotcha.
Yeah. When you look at the studies, the risk of malignancy for a Bethesda 6 is between 98 and 100+%. So naturally, some of the cases are going to be very rarely 1% or so that the Bethesda 6 call is going to lead to either a neoplasm are commonly the oncocytic nodules, because the oncocytic cells, which we used to call Hurtle cells, can have very atypical nuclei. And sometimes these patients also have chronic lymphocytic thyroiditis, which we know can cause horrific reactive change in the nuclei, because they are being bombarded by all these inflammatory cytokines. So yes, it does happen, but very rarely it does. So, and I have seen also cases in which, and I'm sure the search path was also read by the same pathology group, but sometimes there are very small papillary carcinomas that are sitting very close to the main focus that is being biopsied, and that may show few cells. And depending upon one's threshold, one may call it Bethesda 5 or Bethesda 6.
Okay, so Lina, let's go to the next slide. Give us a little more information. We'll bring Dr. Alexander and Dr. Newbold into the discussion here. Go ahead.
So given the location of the nodule that was in the isthmus, and he did not have any additional nodules bilaterally, we offer him the possibility of isthmusectomy, but the patient didn't go through any surgical procedure. And as you can see here on the table, his thyroid function has been remaining stable since 2020 when we start to see him. So the next ultrasound, you will see that since 2020 to 2024, basically the tumor has not grown in the last 4 years.
So Jeff, I know it's not fair to have you look at two isolated ultrasound pictures without your hand. What's your initial thought when you look at this, understanding different planes and all that stuff?
Sure. Yeah, I was surprised that it didn't grow just based on these static images. On the left, wasn't very impressive. I'd give it a TIRADS 3 at most, only based on the fact that it's solid and it's isocoic. I wouldn't give it anything else. The lobularity, and it looks bigger to me on that side, but the lobularity is worrisome. That's something I would push it more into category 4, and given the size, it's 1.4, 1.5, we would biopsy. On ATA, yeah, same thing. I'd give it low and then an intermediate there. We don't have calcifications, but the lobularity is worrisome, and that always pushes my hand into a biopsy.
So Erik, this is a real case. You run into these. How do you deal with this? I mean, we told him years ago to do a surgery. He hasn't. The ultrasound report is saying really no change in size. How do you deal with this and follow with this?
I mean, I think you meet the patient where they're at, and every patient certainly deserves their own autonomy and whatnot. I think, as we all have gone through clinical medicine, you try and find the ability to keep the conversation going, and you certainly don't want to lose the patient knowing that you're dealing here with a malignancy. And certainly you can acknowledge there's some data that we can follow some malignancies conservatively, non-operatively, and they do fine, but there certainly are others that do not. And the only thing I would share, and maybe this comes up in conversation 2 or conversation 3, is there is some intriguing new data that isthmic nodules are not only higher risk, but molecularly different. And I've never understood why that is, but it is some new data that has caught the attention of many of us. So I would follow him at least every 4 to 6 months or so and keep the conversation going.
Kate, this seems to be a discussion I'm having more and more, because we can never get the pendulum in the middle, right? It was like everybody needs surgery. Now people come to me and say, well, we heard you two never do surgery. In England, are you having this same sort of situation, or?
Yes, absolutely. And actually, it's, the lower the risk, the more complicated the discussions are becoming, I think, almost, because obviously if there is a higher risk, the decision is more black and white. And absolutely agree. We're having more of these discussions, and it's quite difficult because we haven't got that level 1 evidence to point in one way, one direction or the other. What we do have is the natural history, which allows us time. And so, with a case like this, again, it does very much, as Erik says, come down to the discussion of the individual patient. Some patients can live with a little bit of uncertainty. Some patients find that they can't, and often that opinion changes for them as well as they go through. And, if they get very anxious before each ultrasound scan, then, you kind of tend to move towards some definitive surgical. And I think with this picture, as Jeff said, even though the size may not have changed greatly, that the features of it I mean, just on that one image, start to look a little bit more concerning, and we may have that discussion.
Yeah, and this is one in particular, the three-dimensional volume helps you. Sometimes you get fooled by you're saying they're only changing a millimeter or two, but when you do the volume, you go, holy cow. Dr. Shaha, you and I follow a bunch of these.
Yeah.
My question always is, if we keep watching, is it going to make your surgery harder, or is it going to invade anything? So how do you convey that to the patient there?
Yeah, if you look at the, I mean, the 4 years is a good time to say, hey, it's time to do something. He bought 4 years without surgery. But if you look at the current ultrasound, if I can use the word funky looking, I don't like it, And that is a new classification, Shaha's classification, funky or non-funky. I don't like it, it is the lobulation that bothers me. It is swinging on one side rather than staying dead in the midline. Maybe this is one picture. So I would definitely push him for surgery. I would tell him that, look, you are going to come to surgery sooner or later. You want to buy another 6 months? Fine with me. But the other thing is, I'm more concerned about the extrathyroidal extension and going into one lobe of the thyroid. So the surgery, which would have been just a mastectomy, may end up with left thyroid lobectomy and mastectomy, because we may not be able to get a good margin beyond that. Something that the patient needs to understand. I think the other thing is, the longer you wait and the more irregular they become, the more likelihood of extrathyroidal extension. And even though this operation is simple, it's the surgeon's responsibility to appreciate the sternothyroid, sternohyoid muscle, which may be attached to that. And you may have to take a portion of the sternohyoid muscle, which normally we don't in most of the thyroid tumors, and look for the Delphian nodes and the pretracheal lymph nodes. These are the first echelon lymph nodes in isthmic tumors, and it's a surgeon's responsibility to clear that area. So at the end of the operation, it should be a nice, naked central compartment.
Erik, most of us are pretty comfortable following papillary microcarcinomas now with observation, and now patients are coming in at 1.4, 1.5, 1.6 centimeters. How does your sort of feel on observation change as you get up in that 1.5 centimeters, sometimes almost 2 centimeters?
I think that's a little bit of the unknown, and I always lead with most well-differentiated thyroid cancer does well, and I was always also reassured by the data out of the Asian teams that rescue surgery, so to speak. So finding something that's worse in 6-12 months down the road seems to not impact overall endpoints. And that was always the reassuring that if you were the 1%, 10%, whatever that number is that were to change, you could catch up. Now, to what Ashok was kind of getting at, I do think you look at some and you're just like, I don't really feel that comfortable with this one, though. And there is something a little unique about what's growing here in the isthmus. So I would use my best persuasive abilities to talk them into seeing one of our good surgeons.
Yeah, as somebody that tries to develop risk stratification systems, you guys kill me with that funky stuff, and I just don't like it. And happy surgeon. Those are all great. They're important prognostic features, but really hard to put in AJCC and ATA risk. Zubair, you put the reference up there for the molecular assessment. I'll take. Can you make any sense out of that for me?
No, I have to read the article first. No. So, I mean, I think they're high. The BRAF or BRAF-like score is high.
Yeah.
Also, and I think it's also, as Dr. Shaha was saying, it's the location. I mean, on the slide, when I look at it, the nodules in the isthmus, there's not much tissue to hold them in, and they invade. I see that extension, and I sometimes worry I'm probably overcalling that because there's not much left there. So, but they do have high, it has been shown previously also, they do have a high BRAF or BRAF-like score. So that, they can be radioactive iodine resistant or more aggressive tumors.
Yeah, interesting. As it's sort of there, and a few papers talk about how the biologic behavior may be different if it's in the isthmus or lobes or that sort of stuff. And even in those small tumors, at least to me, it feels like they preferentially live sort of subcapsular. I mean, It doesn't seem like they are evenly distributed through the thyroid. So I wonder if it may not be the lobe, but it may be that location relative.
I think it's a real estate, to be honest.
I do.
And Dr. Lavolsi always said, be careful with isthmus nodules. So.
Yeah. I do too. I think it's that microenvironment stuff. Okay, let's see. Do the next slide for me there, Dr. Pedraza. And let's see so we talked about the location. We talked about the growth rate. Oh, this is a great question. So we'll do this to Kate. Kate, so the good Dr. Shaha does an isthmus and a hemithyroidectomy. And 6 weeks after the surgery, the TSH is 4.5. We'll pretend this is a 1.3 centimeter papillary thyroid cancer confined to the thyroid. Nothing else special about it at all. What do you do with that TSH?
Well, I would say that the practice in the UK is pretty varied on this. Some of the guidelines now do recommend that we bring the TSH down to the lower end of the normal range. And so I think we've probably moved towards that. For a while, we didn't suppress because, you know, one of the benefits of not having a total thyroidectomy is the patient isn't having to take the thyroxine. But our national guidance has changed to suggest that we do try to bring that TSH down to the lower end of the normal, which for us would be kind of 0.3 to 2, 0.5 to 2 in the US guidelines. So yeah, I think we probably would in that instant.
Gotcha. Erik, what do you really do? Real practice, your practice?
You know, I think there is kind of a graded impact of a lower TSH, meaning a beneficial impact. With lower TSH, the worse your tumor is. And it's probably kind of a linear process. You know, having said that, the pendulum has absolutely shifted, and we're doing much less suppression. And there was some recent data that I guess I read the other day that, you know, in low risk disease, and I guess that's what we're assuming. Maybe we hypothesized here. Maybe there's not much benefit. So, you know, to me, I don't like a TSH of 4.5 initially. I think the bigger factor to consider clinically is certainly as you deal with someone over the age of 50. Long term, I don't like at all the idea of a TSH that's truly suppressed, less than 0.5, because I do think the data as you get older and the association with AFib is real, and that's a bigger, harder endpoint I don't like. So if you're going to do it, is what I'm getting at, I probably would do it for a year or two, and then I'd loosen it into the normal range.
Yeah. So our just from a practical standpoint, we try not to use levothyroxine. These guys, the first TSH that comes back about 6 weeks after surgery is often 4, 5, or 6. And if you don't do anything for another month or two, they'll often come back at 2 or 3, which makes you feel a little bit better. So in a guy like this, that obviously one of the reasons he didn't want surgery was go on thyroid hormone, we will give him the option. But it is a graded thing. The more I worry about them, because we do lobectomies on stuff that's not low risk, I will push their TSH down sort of the 1 to 2, recognizing the ATA guidelines completely made up less than 2.5, because we were trying to move everybody away from undetectable TSHs, and we thought people would accept a 2.5 as a baby step. Okay, last question on this one, Erik. What about one of the thermal ablation options for somebody that doesn't want a surgery?
You know, the majority of data, of course, relate to RFA and other non-surgical options in benign nodules, showing the reduction in the structural disease and lack of growth. But really, the data as to treating malignant processes, I think, is a lot less certain. And in this case, where it's right there on the isthmus, not a good location, I would not be a fan of RFA for this one.
Okay. Dr. Pedraza, any questions that you wanted clarified or that we missed on this one?
No, I think we cover everything.
Beautiful. Let's do case number 2.
Okay, so we have a 50-year-old woman with an incidental finding of a neck lump, and the ultrasound showed 1.9 by 1.5 by 1.9 centimeter solid hypoechoic right thyroid nodule extending beyond the capsule, and also avoiding the posterior capsule. You can see it here on the transverse and the sagittal view. She was having some right side lymph nodes also suspicious, and she had an FNA that revealed a Bethesda 6 PTC.
So Jeff, help me out with this sort of the ability of ultrasound to detect that, you know, small extrathyroid extension. Sometimes it seems like it does, other times I don't see it. Help me with that.
Sure. So here you can see it. It's coming out over and it's coming into the strap musculature. We still have plenty of room here for the recurrent laryngeal nerve issue. I don't really think, I wouldn't call this a budding. There's plenty of space here. So I'm not worried about it. And we'd be more worried about this than that anyway. But the fact that it's extra, you know, it's got extra capsular extension, their nodes, we're looking for a total thyroidectomy of this. But again, meticulous detail and just literally moving your hand this much. You can hide the extracapsular extension or you can show it.
Yeah, it's been a challenge. But I think particularly on the small papillary microcarcinomas we've been following and trying to tell if there's minor extrathyroid extension. It's been a challenge. I mean, sometimes we call it and it's there. Sometimes we don't see it on the path report. What is it about the ultrasound features itself, Jeff, that tells you it's into the capsule or through the capsule, just sort of in general? How do you look at that?
It's difficult. It's a listen, you can have micro extension out that you'll never see on ultrasound. It's a contrast resolution thing. You're bounded by the physics of it. But if it's something like this, it's easier to tell. You could just see it budding out. It's salivular. It's coming in. It has mass effect. And what we do now is when we worry about it, we just have the sonographers take clips so we could look through all of it. So it's not as operating dependent. We don't rely on the static imaging. And sometimes that CT will help. It'll show that haziness. It'll show sort of a little bit of spigot, not necessarily gross disease, but just a little bit there where you don't see that nice fat plane, and that's when you know that it's extracapsular.
Kate, in a case like this, we got a papillary cancer, 2 centimeter. Assume there's no other lymph nodes, nothing in the other side of the thyroid. This is all you have on the ultrasound there. Your initial surgical recommendation is you point them to the surgeon is going to be lobe or total, or what are you going to tell these guys?
Well, we have a trial running in the UK between hemithyroidectomy and total thyroidectomy. So we would see if they fit the eligibility for that. And then because we haven't got the results of that trial yet, we may be, and if it's going out extracapsularly, extrathyroidal extension, we would probably still lean towards a total in this situation, but it is variable.
So Erik, Ashok often consents these guys for either lobe or a total. What happens if he gets in there and he takes out that right lobe and there's no gross extrathyroid extension? Strap muscle's not attached to it. It's just a clean right lobectomy. Do you tell him to stop or go ahead and do the total thyroidectomy?
I kind of respected a surgeon's choice in the moment, obviously, and I think the harder one is the patient comes back after hemithyroidectomy. That was the best surgical option, despite being consented for both. And then you find something that's kind of in the gray area a little bit. Though I will say increasingly, if you go back 10 years or more, we routinely did, completions, and now we just don't. And certainly there hasn't been a big uptick in death from thyroid cancer. So, I think increasingly it's harder to have the informed discussion with the patient, but then for them to choose to go back for a second surgery. I'll just end by saying the one thing you do get with a completion, with a near total, is you just on the endocrine side of things, you do get much more sensitivity to follow-up and detecting recurrence, which certainly can happen.
Yeah, and the more we rely on that, the higher risk on that post-op thing. Dr. Shah, for the non-surgeons in the audience, you're looking at this, obviously you're going to be worried about strap muscle. How do you sort of step through that intraoperative decision-making for me?
I just want to go back. There is the extrathyroidal extension, which is divided into minor, which is fairly common, and the gross extrathyroidal extension. The surgeon's responsibility is to take out all the tumor that he can feel and see. And don't be too surprised, the final pathology report in this patient comes minor pericapsular adipose tissue involvement. And I have a strong feeling, I do this myself, I take out the inner strap muscle, sternothyroid. It has no function, it is a vestigial muscle, but it gives you a sense of security that I have done an oncologically sound operation. Keep in mind, the thickness of the thyroid is barely 1 centimeter. 3 centimeter by 2 centimeter by 1 centimeter. 1.9 centimeter thyroid tumor has to be under the capsule of the thyroid. The only time I would consider going back and completing the doing a total thyroidectomy is major vascular invasion, which you don't appreciate clinically, radiologically, till you get the final pathology report. And another time I would consider doing total is at the time of surgery, I see a bundle of large lymph nodes. There are 10 lymph nodes. Then I know this patient will be benefited by radioactive iodine. What we need to appreciate, and I think the question was brought both by Erik and Kate, when do we consider completion thyroidectomy? When we feel that this patient would be benefited by addition of radioactive iodine. And that can happen only if there is a major vascular invasion or 10 lymph nodes positive. There is a 11th one which we are not appreciated. Otherwise, there is hardly any reason, no matter what the final pathology report shows, to go back and do a completion. We also have to put in perspective the quality of life difference between lobectomy and total thyroidectomy. I think we have never paid attention to that. We have been having a reflux phenomenon about lobectomy at Memorial and total thyroidectomy at other institutions. And I think we need to get away with that, with the understanding of the quality of life and the long-term outcome.
So Dr. Pedraza, tell me what happened with this patient.
So this patient underwent a total thyroidectomy with right central and right lateral lymph node dissection. And as you can see here in the pathology, it was basically a 1.7 PTC tall cell variant. There was no vascular invasion, but there was extrathyroidal extension. She had 2 of 3 central lymph nodes that were metastatic for PTC, and the largest was 1.3 centimeters. No extranodal extension, and then she had 4 of 35 right lateral lymph nodes that also showed metastatic papillary thyroid cancer, and the largest one 0.6 with no extranodal extension. Her labs post-surgical showed that normal TSH free T4 of 1.7 and TG of 0.9 and negative antibodies.
And Zubair, help me understand. I mean, I see this report that says tall cells all the time. Help me understand what this tumor is and sort of how do you understand it?
So this is basically based upon morphology, where the cell size, so cell length is 2 to 3 times the width, and they tend to have more pinkier and oncocytic cytoplasm, and their nuclear features are readily identified. So if you take all tall cell subtypes of papillary carcinomas and do FNAs on those, they are going to be, I will say, greater than 90+% will be outright callable as Bethesda 6. And then you need to have 30% of the tumor that you're examining under glass to have those features to be classified as tall cell subtype of papillary thyroid carcinoma. But the recommendations are, and which the literature also shows, that even if you see a minor component, you should mention it, that it is a classic subtype of papillary cancer, but it has features and which is less than 30% given whatever the ratio you calculate, because it has shown those tumors also behave differently than a classic subtype.
Yeah. Erik, I'm trying to sort of risk stratify this tumor in my head based on all these things. The number of lymph nodes, the size of lymph nodes, the percentage of lymph nodes, how do you factor that into how you think about the risk? Not necessarily whether you're going to treat him, but the risk.
Yeah, I think a little bit depends on the extent of dissection, but assuming they looked and they found everything they could find when they removed, you know, I think if you're, in particular, the size of the lymph node is important to me. And when you get down to millimeter-sized metastatic nodes, meaning, you know, 2-3 millimeters or smaller, I think you're dealing with no impact there on kind of your risk assessment. Consider those almost irrelevant. When you get into, you know, 1 to 2 centimeter nodes, it's certainly real. And here we're dealing with like 6 nodes. I think this is substantial disease and hence N1B. I also will just say I look at for extranodal extension as a particularly bad adverse finding on path that can sometimes tip me over on next step decision making, and it's good that this patient did not have it.
Good. Kate, help me understand in this one, 1.5 to 2.5 centimeter range, how that specific tall cell variant versus classic versus solid versus poorly differentiated, everything else remaining the same. How does that potentially aggressive histology think about how you think about risk stratification or how you're going to move with your treatments?
So we still use it as a factor that tips us towards considering radioiodine ablation, and that's because those factors, so tall cell variant, columnar variant, were and N1B disease were excluded from our trials, the high-low trial and the estimable trial in reducing your ablation activity that you administer. So we still use this as a factor that informs our decision about whether to give iodine ablation and then subsequently which activity we're going to administer.
Dr. Shaha, if I don't know you and I'm looking at op report as somebody from the outside, as an endocrinologist, what's the things I need to look at in your op report on a case like this that, I've got this extrathyroid extension on the pathology report, but what are the stuff you're going to put in the op report that would be, critical for us to know after surgery?
First of all, before the pathology report, you need to know the surgeon. Because I think that does make a difference. And what's the philosophy of the surgeon? I think that is one important thing. In this case, if you see the lateral nodes, there must be something. We don't do prophylactic lateral node dissection. So they did the lateral node dissection. They found 35 nodes. So this is something more that they were prepared for. So what are you looking for? Number one, the surgeon should describe in his operative report what he felt at the end of the surgery. Did all the tumor come out? Was there gross extrathyroidal extension? I'm not talking about minor. That he won't be able to tell. Was the tumor stuck to the muscle? Probably yes. So he should describe that. The other thing he should describe is were there clinically apparent lymph nodes that he removed. Now, Erik made a very good comment on this. 1.3 centimeter metastatic focus. That's not good. That's pretty large. That node was very obvious at the time of surgery. We don't hesitate to get frozen section at the time of surgery, primarily because Hashimoto's is so common and the Hashi lymph nodes are so common that the more we dissect, the more we're likely to hurt the patients. So I think in the clinical picture, the surgeon should describe about the primary tumor, the lymph node metastasis, gross extrathyroidal extension, and then what is happening to the posterior border of the tumor. Was it stuck to the nerve? Did he have trouble dissecting the nerve? Was it adherent to the trachea or esophagus? I think those are the important points, which probably we don't write in the operative report, but a good surgeon should communicate that with the endocrinologist that, look, I did a good operation, but I'm not happy at the end of the operation. I'm concerned. That's a good indication for doing something more or radioactive iodine.
Awesome. All right, we're gonna put a vote out here and see what we really do. Don't give me any platitudes. Don't tell me about guidelines. Don't tell me patient preference. It's one of those patients that says, "Doc, I paid you a lot of money. Just tell me what to do." There's a reason I flew all the way to London to get this opinion. So radioactive iodine, yes or no? London, Dr. Newbold? Yes. Boston?
Yes.
Oh my Lord. Dr. Shaha?
Yes.
I
will kiss your hand, Mike.
Dr. Pedraza?
No.
It's because Lina's rotating with me. So I know I'm probably the only person in the country that would tell this guy he probably does not need radioactive iodine. I'll agree with you guys 100%. What you identified was risk factors. No question about it. This guy's at high risk of recurrence. The qualm that I would have is whether radioactive iodine is going to impact that risk of recurrence, right? So I think in the ATA guidelines before, we had sort of really talked about risk and treating because of risk, but in oncology, you have to take the second step, right? And said, what's the benefit? If this was a medullary, we wouldn't treat with radioactive iodine, right? We all agree that high risk, but there's no benefit. So over the years, I've really come, particularly in these tall cells, to give the patients the option, and in fact, lean toward not doing it. It's a long discussion where I'm going to say, I'm not going to give it to you, and you're still likely to recur. That's a difficult discussion to have. But because this was not one of my patients, Dr. Pedraza, what happened to this patient at Memorial?
So I have a little bit of this slide for discussion, but I think we cover. So what happened was this patient in another hospital received 150 milligrams of radioactive iodine. And as you can see here on the SPECT, it confirmed the uptake on the thyroid bed and the intense uptake on the right level 3 lymph node.
So help me here, Kate. You know this is a trick case, and you know I'm going to show you one that radioactive iodine didn't work to prove my point. But in a lesion like this on SPECT CT, no question, this place grabbed onto radioactive iodine, and almost probably the same as sort of pyramidal lobe there. What would you tell the person the likelihood that destroying this lymph node on ultrasound, it was about a centimeter, a little bit bigger, something like that?
So generally, we would suggest that radioiodine has most of its effect with microscopic disease, obviously, so a sub-centimeter. And, if in follow-up we identify a lymph node that's centimeter or more, then we would usually go towards surgery before we would consider radioactive iodine, because the chances of iodine, certainly on a one-off administration, in getting rid of that, they're low. In this situation, the patient's had it. We would then monitor and see what the effect has been, and that would be with ultrasound to see what the anatomical effect is, and also biochemically as well.
Dr. Shaha, help me here. I read the op report from the surgeon, and it said he took 35 lymph nodes out on the right-hand side. That's a respectable number.
Yeah.
And yet we have a leftover 1 centimeter lymph node. How's that happen?
This is a commonality. This is a missed lymph node. This is and most probably the surgeon had not done the CT scan, most probably, because he would have seen that lymph node and he would have been more kind of inclined to, even though he cleaned up very well, this lymph node was missed. Now I completely agree. Whether the radioactive iodine is going to help or not, we don't know. Could he buy time and not rush into second operation? I think I would, because it is quite likely that this is the 5th node, there is a 6th and 7th node, which will bring him to the 2nd, 3rd, and 4th operation. I would rather avoid that and conglomerate that into one nice operation at a best time when the lymph node has increased in size or there is some concern.
So Erik, from a real practical standpoint, what do you tell this guy? How do you do his follow-up? Radioactive iodine apparently did what we wanted to do to start with. What do you set these expectations?
Yeah, I usually tell them, after the kind of shared decision making, that we walked through and decided to do it. And I might just make one editorial. 150 millicuries is beyond probably what 9 out of 10 people would give. So I just want to make sure that wasn't the Boston recommended dose. Probably 30. Okay.
It was probably Philadelphia. You can't.
Same effect, right?
I totally made that up.
But I think, the way I approach it now is I say, look, there's kind of a standard upfront treatment, which is surgical removal. And if you consider it radioiodine ablation, and you've done that now. And now it really is about following you over time, and let's see if it did the job, right?
Perfect. Sounds good. And so we're going to follow. And where did we go from there, Lina?
So here, this table, what it want to show is the trending of her thyroid function and the thyroglobulin. As you can see, after the radioactive iodine that was on this date, she has suppressed thyroglobulin. But on January 2024, we had an ultrasound that shows a right level 4 lymph node that was measuring 1.2 by 0.7 by 0.6, and a year later, with a normal TFTs and suppressed thyroglobulin, we had an ultrasound that showed the same lymph node that was increasing size to 1.4 by 0.8 by 0.9 with the presence of microcalcifications.
Hey Jeff, help me understand these repeated ultrasound measurements. I mean, what's the variation I can expect, from experienced ultrasonographers?
So Memorial, we use 3 millimeters in short axis as our standard for through increase. And, at the lateral neck, 7 millimeters of the short axis is what our cutoff is. However, size is irrelevant when you have concerning features like cystic change and microcalcifications that are true microcalcifications that are cortical and not just a little perivascular fat that's often mistaken for microcalcifications. So 3 millimeter and any concerning features and or change in reniform shape, more rounded in appearance, peripheral vascularity because the tumor does hit the cortex first before it invades centrally into the hilum. But, these little size variations, it's not, to me, I would have reported this as really no change, 1.4, 1.2. But again, you can scan it 5 minutes later and give you a different thing. So really 3 millimeters is our threshold, but this, I would just say, is stable. The microcalcifications, if they truly are, well, that's, of course, it's nodal disease, and it probably is. And, by the way, many lymph nodes that harbor micrometastases show absolutely nothing, but on path, we know that they were positive for disease. And
Yeah.
we see that all the time.
Kate, in terms of response to radioactive iodine, the timeline, I mean, we have a pretty good feel from external beam radiation, but we'll call this lymph node the same or maybe slightly bigger is what we'll call it for right now. If I wait longer, are we still going to get effect of radioactive iodine?
I think so. My experience with macroscopic nodes following iodine uptake is that they won't go away. It's just a question, you'll probably always be able to see them, and they probably will always look abnormal structurally. But the question is whether they're active, and so that monitoring is key with the ultrasound, is to see if there's any significant growth. I think you don't want to put a needle in it too early, because it will be positive, and then you're kind of thrown as to whether it's viable, or not. But yeah, certainly you can still see effect of iodine, up to a year afterwards. We know that from our ablation, and why we don't do the dynamic risk stratification too early. So I wouldn't rush into anything.
Erik, any role for another dose of radioactive iodine now or at some point in the future? This was RAI Abbott.
No, I rarely, in the last decade, I can't even think on one hand how many times I've double dosed. I mean, other than the setting of redifferentiated disease for advanced, not this, scenarios. So no. The only other thing I would note, though, is in the era, just, as we're all clinicians here, in the era of patient-facing notes online, the loaded concern that an ultrasound reads bigger and microcalcification leads to a Google search, and quickly it's very hard to stop the train sometimes to not do something, right? I agree with everything, but it's worth noting that, right? So how we word all of our notes, not to, in any way take away the real data, but it can be so impactful on the patient decision.
It totally does. Even words like 5 millimeter thyroid bed mass, because mass has to be huge, right? So that wording and stuff. All right, Ashok, we follow a bunch of these. We've talked about detectable versus actionable. What's going to drive you to actually do something here?
I think, this is where the judgment comes. And I like to get a CAT scan to see what we're looking for in the CAT scan is the location of the tumor. Remember, when the radiologist refers level 4, it's a very big area. It's an entire Siberia. You need to know where the problem is. Is it next to the trachea? Is it adherent to the trachea? That's very important. Is it adherent to the jugular vein? Is it causing indentation on the jugular vein? Is it between the jugular and the carotid artery where the vagus nerve is? I think this is very important. And when you talk about detectable versus actionable, I think these are the points that go through our mind. The slight increase doesn't bother me. He's going to need surgery. He's 54. One day he will come to surgery. What is the best time for surgery? Probably we could monitor him, and rather than repeating the ultrasound in 1 year, I would do it in 6 months, and maybe in a year and a half, I would repeat a CAT scan and compare the 2 CAT scans. So I think those are the important issues when we think about it. The one thing I need to be absolutely sure that in next 6 months, he doesn't come up with one more node at level, another level 3 or level 2, which will push me into surgery. That the last thing I want to describe is, if you are thinking about not doing surgery, don't put a needle in it. Because once you put the needle and that is positive, there is no way, Jose, you're going to stop operating on the patient.
Yeah. And in my own defense, since we gave him radioactive iodine and he had persistent disease, nobody feels bad about it. If I wouldn't have given him radioactive iodine and we were looking at that exact same lymph node right now, we'd feel bad about it. When in fact, we probably didn't make much difference at all. So that's where okay, so Lina, what questions did you want to finish with us on this one?
I think we covered most of.
Okay, so no second dose radioactive iodine. We talked about surgery. And I really do think active surveillance in these guys. I don't follow these alone. I follow these either with usually a surgeon or a really good ultrasonographer because it's all about location. All those details you heard Dr. Shaha talk about. Yeah, I know where level 4 is, but where is it within level 4 relative to the nerves and the vessels and that sort of stuff? And every once in a while, it'll look to me to be lateral, and he'll call me back and he'll go, no, this is really sitting right on in a bad location to take a look at. So having our surgical colleagues that really understand the anatomy of those. I often tell patients, if I ask the surgeons, if it got bigger, is it going to grow into anything? And if it got bigger, is it going to make your surgery harder? Those two questions would help us kind of know to move in the right direction. All right, Dr. Pedraza, you're on a roll. Let's do some more practical. Let's try one more, see what we get on number 3 here.
Michael, can I just bring up one point? If
Sure.
the lymph node is below 1 centimeter, be careful as a surgeon. You may not find it in the operating room.
Particularly in the smallest dimension, right?
Small dimension, and there is a lot of scarring and fibrosis. And remember, the surgeons are always scared in the operating room. We don't show that in the conference or in the outside the operating room, but we're worried about the bleeding. We're worried about the recurrent laryngeal nerve, the vagus, and the jugular proximity. So if it is below 1 centimeter and you are thinking about not operating, avoid doing needle biopsy.
Yeah, I sent one of my thyroid cancer fellows, I think this was Dr. Robenstock years ago, to the operating room to have him watch a 1 centimeter pretracheal lymph node taken out. Should be a chip shot, right? And I think it was AL. And when he came back after the surgery, he said, I learned that 1 centimeter on an ultrasound screen is a lot bigger than 1 centimeter in somebody's neck. And so that sort of helped reset where we were. All right, Lina, let's talk a little bit about the next case.
Yes, so we have a 27-year-old man who underwent a total thyroidectomy in October 2024. He had a history of hyperthyroidism, and prior to surgery, he was prepared with methimazole and beta blockers for the procedure. He came to MSK for further treatment, and then the pathology review here showed a left 3.5 centimeter poorly differentiated thyroid carcinoma, completely encapsulated with extensive capsular invasion with marked mitotic activity. There was no necrosis, and there was extensive vascular invasion of 7 foci. No extrathyroidal extension, and the tumor present at the surgical margins. 3 perithyroidal lymph nodes were benign, and at the time of the visit, we have this a thyroid panel that showed that 3 months after the surgery, his thyroglobulin was 5.9.
Zubair, take a couple minutes and help me understand this. Your guys' new terminology of poorly differentiated versus high grade differentiated. Where do we sort of put this in that sort of spectrum?
So, I mean, not much has changed. I mean, if you really look into it from the earlier classification, but what we have done, we have created an umbrella term of high-grade follicular-derived, that means follicular cell-derived carcinomas, and that includes the classic poorly differentiated, which was based upon the criteria from what we call as Turin criteria. And now we have brought in also these well-differentiated carcinomas. They look like papillary, they look like tall cell, or they look like columnar cells, but have necrosis and mitosis, which is greater than 5 per 2 millimeters square. But the criteria for the poorly differentiated for diagnosing it stays the same, but it is under that term of high grade because these have that intermediate to high, the prognostic on the risk stratification.
And they signal RAS-like, BRAF-like? Do you get a feel for?
So if it's a papillary thyroid carcinoma, which is high grade, they are BRAF or BRAF-like, but they can have additional, like a TERT promoter and stuff. Whereas the poorly differentiated carcinoma, depending upon which tumor it's coming from, so most of them are RAS, and then they have a layering of other additional mutations or fusions.
Perfect. So, Erik, I'll come to you on this thyroglobulin level here. I mean, we're already thinking this is potentially a higher risk. We're worried about distant metastasis, all that vascular invasion. What do you expect the thyroglobulin to be afterwards? And this one came back at that 5.9. Happy, not happy? What do you think about that?
You know, as Ashok kind of mentioned, you get to know your team and your surgeons, and you kind of fit within kind of the remnant that's normal for each surgeon. Everyone operates a little different. This is a little higher than we would typically see postoperatively, but it's not 40, you know, or something like that. So it's kind of in that middle ground. I find poorly differentiated carcinoma to be worrisome, that sometimes it can go bad. Other times it does just fine. It's kind of a very wide range, large standard deviation around this pathology, in my opinion.
So, Eric, I don't know anything about Graves' disease other than how to spell it usually. He had Graves' disease before surgery, no data whatsoever. Do you factor that in as maybe that's why the thyroglobin's a little bit higher? He probably still has TSIs and whatever remnant tissue, or am I just making that up?
You know, it's stimulating the TSH receptor, which is a natural growth factor for the cells. I think the clinical reality that that's ever shown to be a negative prognostic factor or a causative problem is nil, really. So I don't lead into that or kind of blame it. I find it a curiosity on that.
Yeah, me too. Kate, where do you go with this? So clearly high risk guy with all this extensive vascular invasion, young, 27, TG of 5.9. And they're sent to you to consider radioactive iodine, obviously, because this is probably going to be a RAS-driven tumor. Do you do more staging? Do you do a post-op ultrasound? What do you do with that 5.9, Kate?
So if there was any gap from the surgery or the patient was coming from another center, then I would do an ultrasound just to make sure that there's no macroscopic disease that's residual that would benefit from further surgery or consideration of further surgery. We wouldn't particularly do any more distant imaging at this point, because we would recommend radioiodine, and then we would use the post-iodine SPECT-CT to fully stage and more sensitively stage. I would probably also do a PET-CT at the same time as my iodine with the poorly differentiated components, so that I would have both a post-iodine scan and an FDG image to look at, just because of my suspicion that, you know, we may have some non-iodine avid disease present, and I would want to make sure we weren't missing anything.
And you could do your PET-CT without iodinated contrast, Kate?
Yes, absolutely. Yeah.
So that if you wanted to go ahead and give the radioactive iodine.
Yeah, we kind of make the most of the raised TSH and do it just after they've had their Thyrogen. We do the FDG, then give the iodine, and so you just maybe increase the sensitivity a little bit by piggybacking onto that.
So, Jeff, we're about to run up against the hour here. Traditionally, I was taught not to do ultrasounds in the first few months after surgery, and that yet my European colleagues frequently, as Kate said, if there's been a couple 3-month gap and they haven't seen somebody, can you use the ultrasound in that first 2 or 3 months after, if I'm just looking for golf balls?
Yeah, I mean, if you're looking for golf balls, I mean, we wait longer than that usually, but we don't expect to find anything post-operatively. Our surgeons are excellent in what they do, and they don't leave macroscopic disease, except for that one caveat that we said earlier, where the patient came back 6 months, and because of a failed ultrasound, there wasn't all that lateral disease, and that was a very, the surgeon was extremely upset. There was a lot of problems with that case, obviously. So, we wait. We don't. If there's, there's not going to be macroscopic disease, and if we would just follow, as you often tell us on DMT, and if it was rising, then we'd have to do some cross-sectional imaging. We, of course, would start with the ultrasound, but then we have to go beyond that.
Perfect. So I'm going to stop us there. It turns out this gentleman had like 25% uptake in the neck and got radioactive iodine, no distant mets or anything like that. But the discussion about where we cut off that thyroglobulin of 5 when you do additional imaging, certainly the higher it gets, the more we have to be concerned that maybe you don't go straight to radioactive iodine, and look and make sure you're not missing distant metastasis or structural disease in that setting. Dr. Shaha, last comments on this. 27-year-old guy, poorly differentiated. As Eric was saying, there's a large spectrum. What's your feel about how this guy's going to do?
In my judgment, he will do quite well because he's young. He has an encapsulated lesion. But what is not good is a major vascular foci of invasion. And he needs to be monitored very closely. If next year his thyroglobulin jumps to 20, that's almost a sign that he has distant disease. And I would be very careful monitoring his thyroglobulin every 6 months. And this is one patient where I would try to keep the TSH below 1 with no data,
Yeah.
as long as I don't hurt him too much. And I would definitely get endocrinologists directly involved. It's not a one-man show.
Yeah.
I think I would, if it was my patient, I would have you come and see the patient or follow with me.
Yeah, you're going to need lots of members of the team potentially on this one. Dr. Pedraza, any last questions on this one before I sign off for everybody?
No. I think we covered everything. These are the images of the remnant, and then I think it was the discussion. We were like hypothetically said that if there was a vocal cord paralysis, but
yeah, in terms of watching and going back in. All right, we are right at the hour at 9 o'clock, Dr. Pedraza, and your mentor, Dr. Boucai, thanks for bringing us great cases that were like really practical things. These are the discussions we have every day in our clinic. If there was great data, we wouldn't be having these long discussions. So thanks to the panelists for just telling us what you do. Appreciate it. Just a reminder, Voices of Wisdom podcasts are out there, and we'll see you back at the next edition of TIRO. Thanks, team.
Thank you.